Good morning. I'm delighted to welcome our guest this morning, who is Dr. Mattia Glauber. Mattia is a friend and colleague. He's the head of cardiac surgery at the San Donato Hospital in Milano, and he also works with us here in Galway, where he consults on minimally invasive cardiac surgery. And we wanted to speak to Mattia this morning. We're obviously in the height of the global pandemic with COVID-19, and nowhere perhaps has been as badly hit as Mattia's home region of Lombardy. So we thought, even though it is Easter Sunday morning, somewhat unusual time for a media piece for Mattia, we would love to get his take on things. And so I'm really delighted, Mattia, to welcome you to the show and to see you. And I trust all is well with you.
Good morning, Frank. It's a very pleasure to be in contact with you and with your country. As you know, I am very happy to give my contribution to Ireland and to University Galway Hospital, and on which we started this nice collaboration and program in cardiac surgery. The situation here in Milano is the situation that probably you heard from the media. And since the 19th of March, we are totally locked down. So all Italy is totally locked down. Lombardy region is locked down from the 6th of March, so even 2 weeks before, and we are facing a dramatic situation, a sort of tsunami in which all our hospitals had to convert from normal activity to a dramatic and emergent ask for new admission. Daily, we had to face with 60, 80, 100, up to 150 new admissions a day for very sick patients. And there was a dramatic need to convert ICU beds and to create new intensive care solution for the patients. And in the beginning, you have to imagine that the Lombardy region has a potential of approximately 500 ICU beds, and after 2 weeks, the numbers of ventilated patients in all the region was 1,500. So we had to triplicate the numbers of ICU beds and to convert any possible solution to create a way to ventilate these patients.
A tremendous problem, and what an achievement to try to cope with that. So I guess one question immediately comes to mind is, why do you think now that the Lombardy region got hit so hard? At one stage there was speculation that perhaps industrial connections with, say, Chinese migrants might have been involved, but what's your current thinking now on why your area got hit so hard?
Surely there is a socio-economical reason, because Lombardy region is a region of more than 10 million of inhabitants, in which the most industries are located, with the highest concentration of workers, and all this in the suburban area of Milano, which is connected to Bergamo and Brescia. So all this linear connection is where the most highest concentration of workers, of connections, of transportation, and especially in the beginning, since that we were the first country in Europe attacked so hardly by the virus, there was even the big so the economists and the politicians were afraid in a crisis that our country was not able to support. So this was a cause of delay. And there was even a big lack of PPE. So the personal protection equipment was not available. We were, as Lombard, even sending to China what we had and to support China. And at the end, we were totally without. So this was even the big, let's say, reason why so many doctors and so many health givers were touched by the virus.
Yeah. We are seeing in Ireland that 28% of the cases involve healthcare workers, and similarly, the PPE issue has been large here for us. At this point, as we speak today, do you have the PPE you need? And is it your sense that perhaps the cases are stabilizing and that we may well be going on to the downward side of the curve?
The numbers of new cases is coming down. In the past few days, we had only a plus 3%, even less of new infected people. The number of patients going home is more than 35%. And unfortunately, we have this high lethality, high mortality, which is more than 4%, 4.5%, which is surely one of the highest. We have to see what will happen in the US, but surely we are with a very high mortality rate. Even if we think that at least the number of positive patients are 9 to 10 times what we tested. Yes. So asymptomatic patients are a lot.
So I wonder then the next issue that we will face, and this is not to say that we're past the current phase by any means, is how do we deal with all the other illness that we know faces us? You're a cardiac surgeon, I'm an oncologist. You know, pretty much we've seen a cessation of all what you might call the non-COVID work. What's your sense of how and when we can get back to doing this kind of work again?
I can tell you in detail what's going on for cardiology and cardiac surgery hospitals. So in Lombardy region, we have 57 cath labs performing approximately 80,000 invasive procedure, and out of this, 8,000 are acute myocardial infarction. And the region decided to keep only 13 cath labs open, spread all over the region, with an H24 on-call activity. And as for cardiac surgery, in the region, we have a lot of centers, 20 centers in Lombardy region performing roughly 10,000 procedures a year. And the region decided to create 4 hub centers in which all the non-elective cardiac surgery could be performed. So doing this, all the rest of the hospital and departments could be recruited for creating ICU beds. Cardiac surgery has ICU beds, so this was a resource that could be used. What is strange is that we observed that 90% of the usual emergency did not arrive to hospital. So we treated only the 10% of the conventional urgent cases. Obviously, this was a great opportunity to share resources between the centers, to apply protocols between the centers, to share surgeons, nurses able to move and go to operate in another hospital. And all these barriers was cut down. So it's surely a new way of working, a new way of thinking, and probably it will be an opportunity to rethink a different healthcare organization.
Yeah, so we have seen the same here, and there's also been an attempt to break down some of the barriers between existing hospitals, and we're in the midst of all that as we speak. So I know you also have an interest in hospital development globally, and you do some work in that area. It may be too soon to predict, but do you see our thinking changing in terms of the hospitals of the future? This epidemic has yet to reach its peak in the developing world, for example. So do you have thoughts on that, even at this early stage?
Yes, sure. I think that we need to build the new hospitals so as they can be easily converted per intensity of treatment. So the way to use a bed as for basic treatment up to the highest level of treatment with all the technology that can be shared and moved and shifted with as the most important the ability to create clean from dusty areas with air circulation, which is the most important technological barrier in all this COVID area. So for a pandemic like this, to have the opportunity to really create a dusty from a clean unit is very, very important. Not only for obviously wards of high intensity department, but for all the rest of the activities that the hospital needs. If you think the laboratory activity or the radiology activity that cannot mix let's say, infected probes or a CT scan for an infected patient that cannot be used for a conventional oncological patient. All these are information that we need to apply for the development of the new hospitals.
So, Mattia, given what's happened and our learning from this, how do we get out of this?
That's a very nice question, because we are discussing a lot on this. And from the disease point of view, What we did here in Milano is that in a very short period of time, just in 1 week, we were able to organize in the convention center a 250 units beds hospital for COVID patients. So once the numbers start to reduce, we think to move patients there so as to let the smaller hospital start again for the conventional routine activity. And this hospital can be open for the next months, and all the patient or all the new patient will be triaged in the different hospitals, and from there, if positive, moved in a dedicated COVID hospital out from all the other regional hospitals. This for the patient. And for the health giver and for conventional people, what we hope, and we are working for this, and we need to test, even if it's really efficacious, we will test the immunoglobulin level and the immunogenicity of each person, so as to give a sort of license to let him go around, walk around and work. It will take time, obviously, but it's probably the most important things to do.
Have you considered the use of technology in terms of surveillance here? I know this is a controversial idea, but we do understand from some of the Asian countries that there's a lot more personal surveillance now using various devices. And of course, they make sense in the context of a pandemic, but we would certainly also worry about the amount of information that will be going into these systems in the longer term. Are you having those conversations about using devices like phones and other things to surveil who is virus-free and who is not into the future?
I think it's very important, and I think that privacy in this pandemic situation is secondary, even because we all know that we can be tracked in any case, giving our, let's say, privacy acknowledgement or not. So if we have someone that can guarantee that after the end of pandemic, all the information will be cancelled, I think we have a formal of social obligation to let us track, and technology is the only way to do it.
Yeah, that's very interesting. I think we have to clearly rethink healthcare across a very broad range. These viruses have been with us longer than we've been on the planet, and for sure will be with us long into the future. So it's a matter of coexisting with them, I guess. And well, Mattia, I hope it's not too long before we get to see you in person back in Galway, where your work is really appreciated and valued as a colleague and friend. So we wish you well, and your family and all your colleagues there, and look forward to seeing you very soon again.
Thank you very much. It's a pleasure, and I hope to come back and to operate with you all again on your patients.
Thank you, Mattia.
Thank you, and happy Easter.
Happy Easter to you and yours.
Yes.